when you take a skin biopsy and you do clinical correlation, we like to think that we can make an accurate diagnosis in majority of the cases, and we can. I'd say probably maybe 85 to 90% of the time. If we have really good biopsy, we have good clinical correlation. But sometimes we just flat can't do it. And so what do you do when you're kind of left in that gray zone and you're not really sure what the answer is? And it can happen in both an inflammatory or a neoplastic process. In some cases, it may be that the disease will become obvious a little later on. You just may not have gotten it at the right time. It may be because it's a reaction pattern that's shared with a lot of different conditions. We'll talk about that. What if the patient's got a funny immune system? We see patients with HIV infection that have weird reactions to things that don't look normal. We see patients that may have had partial therapy and things don't look normal. Like, for example, people that get that psoriasiform dermatitis associated with biologics. That doesn't look like classic psoriasis. And then sometimes there are infectious diseases. We can't identify the agent or poor differentiation. So this is something we see every day in our laboratory. We'll see a suppurative granulomatous dermatitis. That pattern really favors an infection. We look at it, we do all sorts of things with special stains, and it's just negative. And this was a guy we had a few years ago. He was an HIV positive immunocompromised patient, and he had this thing, took a biopsy. It had this sort of diffuse degenerated collagen with some granulomatous inflammation there. We just knew this had to be an infection, but we stained it, we did everything to it, we cultured it. We just flat weren't able to get a diagnosis. This was a phyte stain here, which was negative. We did an immunoperoxidase stain. So what did we do in that case? Well, the first thing, just don't forget about other tests. Dermatologists have diagnosis / biopsy is the reflex, but there's other things you can do. Don't forget about blood testing, skin testing, smears. Those are sometimes things that show you information when a biopsy doesn't. My good friend Stu Brown, he used to talk about injecting it with steroid, and if it's an infection, the organism is going to grow, and then you can rebiopsy. Well, that's maybe a little bit medieval, but it does work sometimes, and he used to recommend that. We now have newer techniques like polymerase chain reaction and other things like that, so remember those are available in infections as well. There's some diseases that just all look the same under the microscope, and clinically they can look kind of similar. All the neutrophilic dermatoses, for example, on that list, a lot of those can look very, very similar, and it's quite difficult just on a biopsy to distinguish that. Now, if someone's got a neutrophilic dermatosis and they have an underlying leukemia, you can say, well, then it's Sweet's disease. If they've got rheumatoid arthritis, you can say it's that bowel-associated dermatitis arthritis syndrome, et cetera. But if you just have a biopsy of that, it can be subtle, and you can't really tell. So this patient's got these indurated, juicy plaques, and even possibly some bully on her palms there, and erosions here on the scalp. That's erosive pustular dermatosis. The first one was bullous Sweet's. And this lady, again, has got maybe one of these unusual neutrophilic dermatoses. So again, these can be subtle and difficult to tell. Nondescript biopsies all can kind of look similar. So in these situations, you really may not be able to tell the difference between Sweet's and rheumatoid arthritis-related neutrophilic dermatosis. So you really have to correlate it with the clinical. So what you really want to do is basically rule out anything that you can. Make sure they don't have an underlying neoplasm or an infection by culturing it if you can. And if the diagnosis remains unequivocal, you say, well, there are neutrophils in there. Let's use an anti-neutrophilic drug that's going to work. So dapsone, colchicine, those kind of medications. And now we have the TNF-alpha inhibitors will work. So if you're not sure, but you know it's neutrophilic, let the biopsy drive your treatment, even though you can't necessarily call it classic Sweet's or one of these things. So just basically it tells you that there's neutrophils in here. The same thing happens with the lymphocytic infiltrates. These can all look quite similar under the microscope. So you get a superficial and deep infiltrate with lymphocytes. Sometimes if you have plasma cells associated with that, you can kind of think of the possibility of Lyme disease, erythema chronica migrans. But they can all look pretty similar. So this lady's got one of these Yesner's-like lymphocytic infiltrates on her face. This lady's got a similar eruption. They both look similar. They have no scale on them. They're pink, and you biopsy them, and they all look like this. They have a superficial and deep infiltrate. If they have papillary dermal edema, it may be more likely polymorphous light eruption. If they have a lot of mucin in there, it's probably tumor LE. But let's say you can't really distinguish them, and you've ruled out things like Lyme disease and those sort of things. What do you do? So here's another example. Shows the same thing. It just shows you this last patient actually did have the tumid lupus erythematosus in this case. So these are all the diseases that can look like this. So you can do photo testing, make sure they don't have weird Hansen's disease, et cetera. But at the end of the day, you may say, well, I'm just going to treat the lymphocytes. I'm going to let the biopsy direct what I'm going to do, and if you've ruled out infections, you can then try treating with Plaquenil, and you'd be surprised how many of those will get better, even though you can't really say, it's definitely this. But just make sure you rule out underlying conditions that can cause a problem. And we see this all the time too. Very frustrating for dermatologists. People come in their office, maybe Matt Zyrus can take care of all these patients and whatnot, but people come in with this itchy red bump disease, and it's often due to insect bites. I usually find that the reverse is true. There are people that come in that think they're insect bites, and they fogged their home, they've done all this kind of stuff, and you can't really say definitively that it is a bite, but if you can find that, you can obviously treat that, but at the end of the day, it may just be this itchy red bump disease that you can't really make a definitive diagnosis of. And so what do you do there? So these are 3 patients that had this. This guy on the far right actually had eosinophilic folliculitis of HIV infection. The guy in the middle lower photograph actually had scabies, believe it or not. It was the cause of his itchy red bump disease. But this is an example of a histology, and if I look at this, I can give you a differential diagnosis and say this looks like papular urticaria or looks like maybe unusual urticarial allergic eruption. You really have to have good clinical correlation, but at the end of the day, you may just be left with an itchy patient with eosinophils in their infiltrate, and so what do you do in that situation? Well, first thing, you obviously look for bites, for bugs. If you find them, that's helpful. Consider that they've maybe got some underlying weird autoimmune process or immune suppression, so make sure they don't have HIV infection. Scrape for scabies, look for background staph or something that can be driving this, because that can happen as well. At the end of the day, again, let your biopsy drive you. So try Xolair maybe, try Dupixent. So say this thing has got EOs in it. I'm not sure what it is, but I'm going to try it. And then you can also use narrowband ultraviolet light. So this is kind of where you're using the biopsy to kind of guide your treatment when you're not really able to make a definitive diagnosis. And so we can help you in that situation. Now, this is a situation you may encounter every now and then, and this is something that clinicians really are not that familiar with, but there's certain situations where you can get pseudocarcinomatous hyperplasia. This is one we see fairly commonly on the lip, where it's verrucous candidiasis. So this guy came in with this lesion on his lip. It was very thick and verrucous. I think this guy had a mild immunocompromised situation here. And obviously the clinical diagnosis was squamous cell. As you can imagine, you're not going to not biopsy that. Well, they did biopsy it, and this is what the biopsy looked like. It's got this marked verrucous epithelial hyperplasia. It's got this dense inflammatory cell infiltrate in there. But there's really not significant cytologic atypia. Most of this is just reactive atypia. And so whenever we see this on the lip, we certainly look in the crusted area, and we'll often do a PAS stain. And this one, you can see it's just loaded with candidal organisms here. Lots and lots of candida in that thick cornified layer. So what do we do here? Well, we treated it, first of all, so get rid of that before you do surgery, before you do anything else. And it may be squamous cell somewhere underlying there with this superimposed candida, so don't just blow it off necessarily, but get rid of the candida first and see what happens. Well, this is what happened to him. So got rid of the candida, went away, and everything looked great. Interestingly enough, though, about 3 or 4 months later, he developed this. And this guy, again, was immunocompromised. He had a real squamous cell carcinoma that developed. The first one wasn't squamous, it was verrucous candida. He actually ended up getting a squamous cell carcinoma later. And maybe you can use Dr. Riegel's medications for that to help treat that today. So this would be one where you might want to consider doing a genetic test, because the squamous cells on the lip, high propensity to metastasize. So kind of an interesting situation where he had 2 things. He actually he didn't have squamous cell initially, he had candida, treated it, went away, and then this developed at the site. This is another entity that's bedeviling to dermatologists and to dermatophathologists. Early patch stage mycosis fungoides. It can look like atopic dermatitis, like one of the other spongiatic dermatitis. In fact, they're often signed out as chronic non-specific dermatitis, chronic spongiatic dermatitis. We order gene rearrangement studies, but because there's so few cells in those, they're often negative. And people do immunoperoxidase stains looking for loss of markers. They're often negative as well. So this is a situation. This guy comes in with this patchy eruption. The one on the right, he's maybe got a little bit of that sort of digitate appearance, so you certainly be worried about mycosis fungoides in a situation like that. Same thing here. And a lot of times I'll venture out and call it probable MF or something like that, especially when I get a picture. And this is what the biopsy looked like. It's just a patchy infiltrate of lymphocytes with a few cells at the basal cell layer. You're going to see a lot about this tomorrow from Dr. Goff, and I'm going to talk about histology of lymphoma tomorrow. But basically, when we see something like this, it's not unequivocally diagnostic of MF. So we try to send these off for the studies. We think it may be MF, but it just doesn't have all the criteria. And so this is the situation where you probably are going to want to biopsy the patient again more than once. You want to follow them, take them to a conference, bring them there. Maybe somebody else has more experience, get second opinions on it. Try to do the genome range studies, but again, those are often negative. So what do you do then? And you're sort of left with, well, I think this guy's got MF, but I can't prove it. Well, I would say treat it. Go ahead and get them on narrowband ultraviolet B phototherapy. Go ahead and consider topical nitrogen mustard therapy. We have one of our exhibitors here makes that drug. And so that's something that is useful. And sometimes just narrowband UVB and high potency topical steroids will cause these things to kind of undergo remission. So that's what you can do when you really just can't totally nail the diagnosis of an early case of MF. You don't want to wait until you get tumor stage MF and then call it MF. It's better to treat them early. The sclerosing epithelial neoplasms, Dipti showed you some examples of this yesterday. We get situations where we see they all look the same clinically. Okay, they're all skin-colored papules. If you get a deep incision biopsy like this, we get home free. We can diagnose this without any difficulty in that situation. So that's a desmoplastic trichoepithelioma. And you got the cysts, and you got the stroma, you got no retractions between those epithelial aggregates. And this one, there have been actually some people suggest that cytokeratin 20 is focally positive in this, but I don't think you really need it when you get a good biopsy like that shows all the criteria. So that the problem is when we get a little superficial shave and we're dealing with these three entities together, either MAC or this or desmoplastic tricho, they can all look very similar on a shave. And so clinically, again, a small white plaque on somebody's lip. You biopsy, they've done a deep enough biopsy. Now we can see these aggregations of these cords and strands of cells. This one's got a little different stroma. It's got more fibroblasts, a little bit of mucin in there. So we would favor this being more of a morphiiform basal cell carcinoma. And then microcystic head neck cell carcinoma, again, it looks the same. So clinically, they all look the same. And if you do shaves of these, sadly enough, you're not going to be able to get any diagnosis. Now, this one, probably not deep enough here. I would have rather seen a punch or an incision here, but this does have these larger cyst-like aggregates, these whorls of squamous epithelium in here. That's more characteristic of this lesion than it is of tricho or a morphiiform basal cell. So we see something like this, we're more concerned about this diagnosis. But this diagnosis is really best made by the depth of involvement, and these things actually can get into nerves. And so the treatment of this basically is Mohs micrographic surgery. You need to map these things out and get rid of these things because they can be pretty aggressive and they can recur and cause problems. So what do you do here? You obviously want to take a deeper biopsy. So often our diagnosis is superficial biopsy of sclerosing epithelial neoplasm with a differential diagnosis. So we can't tell you for sure which one it is with any technique. So I've never been convinced that CK20 really works here. So what you really need to do is take a deeper representative biopsy. So the problem there has to do with just the sample is not what it really needs to be. So there's some other sort of uncertainty that can rise in some other neoplastic conditions, probably in the melanocytic category. We talked about that yesterday. Again, if we're going to order one of these tests, make sure you talk to your patient, say this isn't like doing a deeper section. It's going to take about 4 or 5 days before we get the result back. I always say, well, how do you tell your patient when you talk to your patient when there's uncertainty? And, you need to tell them, the pathology is not 100% certain here. A lot of these diseases, my granddad used to tell his patients that they just don't read the textbook. And people kind of understand that. And if they're understanding people, they'll kind of work with you and let you get these tests and whatnot. And then in some cases, when you say, well, I'm still not sure even after all these tests, what do you do in that situation? Well, then maybe excise the lesion, maybe consider one of the new prognostic genetic tests for the lesion if you're not really sure. These are a few other cases I've had over the years where there's uncertainty, like a subepidermal blister that looks histologically just like bullous pemphigoid, but has a negative direct immunofluorescence. We'll perform ELISA there. Sometimes it's positive, even though the direct DIF is negative. It may really truly be pemphigoid. In other cases, it may be related to an NSAID the patient's taking, a non-inflammatory sort of PCT-like blister. Non-specific paniculitis, obviously rule out infection or factitial, and in some cases, Joe Giurizzo said he just treats those people with methotrexate, and they do well, low-dose methotrexate. Vasculitis without a cause, sometimes there you just treat with an anti-neutrophilic agent like dapsone or colchicine. You really think it's nail fungus, but there's negative cultures in PAS. Make sure you're not missing a cancer or a melanoma that's amelanotic, like Adam showed the other day. And then chronic spongiotic dermatitis, where you just can't really nail the diagnosis. Then you may just have to treat with things that are going to diminish the inflammation. If it's on the leg in a stasis-associated area, remember Una boots work well. If they're really itchy, you can get a topical vibrating pin and put on there and have them do that instead of scratching the area. You got to stop them from rubbing and scratching it. And the last thing is, kind of be aware of the red herring clinical history that misleads you. So every patient that goes to a foreign country, they come back and the dermatologist says, oh, they have to have some kind of tropical disease because they went to Africa. Well, the most common diseases people being bring from Africa are just staph, strep, or tinea or something like that, or they go on a cruise and they get something minor. But you do have to at least think about it. And, traumatic lesions too, remember that. I mean, we've seen cases of lupus that are traumatized and it was called trauma before, could have an underlying neoplasm. So hopefully that's helpful if you're in a situation where you're really not comfortable with something and you don't really have a definitive diagnosis. That'll help you guide the way.